So please, Kathy.
Thank you, Aya. We all know that the theme of this meeting is translating evidence into practice, and I think that sets the scene for what I'm about to say quite nicely. Aya and Roger have given us overwhelming evidence about the lack of evidence for efficacy of opioids, for long-term pain and the considerable harms associated with prescribing. And I'm sure those of you who watch the literature realize that every paper that comes out or every review seems to confirm what we know already. Where the disconnect seems to occur is actually using that wealth of knowledge to change prescriber behaviour, because we know that despite there being guidelines around for well over 2 decades, prescribing of opioids continues to rise relentlessly. So somehow we're not getting the message across. And I'm going to, in this brief session, I do have a session overview slide, which seems to have disappeared. I'm going to talk about what problems we're trying to really solve here. And I'm going to talk a little bit about guidelines. I'm going to talk about a couple of initiatives that we've been running in the UK, which sound a bit left field, but I think they maybe point a new direction for changing prescriber behaviour. And then finally, I'm going to talk about the current UK opioid prescribing resource and a little word about stopping medicines. So I think the first thing is that whenever we have any sort of meeting on opioids or any conversation about opioids, there are a number of things which I think are quite discrete entities, which tend to get conflated really. Discussions about opioids tend to dip in and out of a number of themes. And the most prominent one is the prescription opioid epidemic in the US. And I think the first thing to say is that we do not have probably the same issues in the UK. So Roger's presented some recent data regarding use of prescription opioids by people for whom they're not intended. And we do have some mortality data, but as far as we're aware, and the various policy bodies are quite vigilant, we do not have the extent of the problem the same as in the US. And this is for a variety of reasons. And there's just a couple of papers here that I co-authored with Dan Weisberg, who was then at Yale, and he spoke at the last EFIC Congress. And these outline quite a number of cultural differences in the way healthcare is delivered, differences in legislation and other influences on prescribing. And we think that there are reasons why we don't have the same problems in the UK. But we do have some problems with opioids, make no mistake. Obviously, our main concern is to make sure that opioids are used properly. And this, I think, could widen out into the use of other medications for pain. But actually, what we're thinking now is maybe that's the wrong approach. And maybe we should put the patient at the center of the conversation rather than the specific drug. So there's a lot of talk about what to do with opioids, what not to do with opioids, whether we should or shouldn't be prescribing Gabapentin and Pregabalin. But let's turn the theme on its head and say that what we're about is ensuring that patients with pain benefit from and are not harmed by their treatment. And that is the focus that is driving our initiatives in the UK, because we are well aware that many, many patients, particularly that we see in secondary care pain services, but we know from primary care as well, that there are many patients on a plethora of potentially harmful pain-relieving drugs who still report severe pain. So those drugs are not achieving their intended benefit. So a word about guidelines, because as I've said at the beginning, we don't find that guidelines have made a huge difference. What are guidelines? They're systematically developed statements that are meant to help practitioners and patients make decisions about healthcare. And what they really are for is to deliver consistent care, so that if you go to Dr. A in City B, you will get the same treatment as you do if you go into Dr. Y in City Z. And they do aim to draw in what we know about current best evidence into clinical practice. And guidelines do have some benefits in terms of improving healthcare outcomes, but very interestingly, even our own National Institute of Health and Clinical Excellence do not assess the effectiveness of the guidelines that they produce. They do help avoid harmful interventions and possibly provide consistency of care, and they can be a useful resource for patients to open up a dialogue with their practitioner, and they can, if properly constructed, influence public policy. But there are potentials for misinterpreting the evidence, and there are conflicts and personal opinions come to bear in guideline groups. Guidelines may not apply to the person that you see in clinic. A lot of clinicians feel that guidelines erode flexibility in decision-making around prescribing, and guidelines can provide an unhelpful focus on rather arcane conditions or interventions, rather than necessarily addressing broader public health needs. And one of the things that we have found that is most difficult is that clinicians looking for sources of information will get inconsistent advice. And as we all know, if you look at 4 different sources of information, all of which tell you something different, you will probably ignore all four sources of information. And we know that complex guidelines just fall into the too difficult box, so clinicians tend not to use them. We know a little bit about implementation strategies, and we know that on the whole, the evidence for varied implementation strategies is much better than single implementation strategies. Although I should comment that the evidence base on the effectiveness of guidelines is very poor in itself. Guidelines may not work because the target audience is not the same as the people who wrote the guideline, and there's a debate about whether the people who write the guideline should be the same as the target audience or not. Patients may not agree with the guideline and may persuade their clinicians not to adhere to them, and the setting in which the guidelines are delivered, we all live with a number of constraints, most notably financial, and it just may not be possible to implement guidelines. And of course, credibility of authors. If you don't like the chair of the guideline committee, you're less likely to, or trust the chair of the guideline committee, you're less likely to follow the guidance. And what we do know very certainly, and this came from some work by Lance McCracken, is that you can actually use an intervention to improve people's knowledge of a guideline, of the information that guideline contains, but it doesn't make any difference to clinical behaviour. So it does beg the question of whether guidelines are the right way to go. And I think there are some assumptions that we make in relationship to guidelines for use of opioids in the long term that may be erroneous. I think opioid guidelines assume that we know what pain is. I think they assume from a starting point that opioids are definitely part of the repertoire, which is why we go to the effort of writing the guidelines. They assume that the treatment plan will be supervised by a single individual and tend to ignore the complex system throughout which a patient moves. They make the assumption, which you would think would be rational, that if a drug doesn't work, a patient will stop taking it. And guidelines also assume that we know about and can recognize risks. But as Aya very clearly pointed out in her presentation, although we know the risks, they are very, very well publicized. There is the issue of adverse selection, whereby people most at risk of running into trouble with opioids are most likely to receive a prescription. And so we've sat down and we've tried to work out where we think things are going wrong with guidelines before we embark on trying to change opioid prescribing practice in the UK. And what we reckon is that it boils down to a poor understanding of the complexity of pain, definitely a poor understanding that it is refractory on the whole. Andrew Moore gave some very good data yesterday showing that for some conditions such as fibromyalgia, medications, for example, will help fewer than 10% of patients. And really no intervention in pain medicine will help more than about 30% of patients. And that is not a well understood statistic. There's generally a lack of awareness, very much, that doing nothing is better than doing something harmful. For some reason, we are hardwired to want to do things. Patients come to us because they want us to do things, and we are complicit in that very unhelpful dynamic. And there's a lack of awareness, similarly, that it's actually okay and sometimes better to stop trying. And of course, all this leads to very unrealistic expectations, particularly on the part of patients who obviously want help in managing their pain, but also unrealistic expectations on the part of clinicians who think that if they keep trying harder or giving more drug or doing something different, they will get a result when they may not. I think guidelines do not reflect the complexity of the drivers that influence opioid prescribing. And there's quite a literature on this. There's another paper that I haven't included here from Amanda Williams and colleagues in the European Journal of Pain. But this is quite an interesting literature, and some of it goes back quite a long way. So the way that the patients communicate with us and the patient behaviour, particularly distress. Distress actually, as I'm quoted as saying, often makes us want to do things, and that's a bad mix. There's quite an interesting literature on the gender of the prescriber, the experience of prescriber with young prescribers maybe following guidelines more and older prescribers following guidelines less. Interestingly, prescribers will express varying concerns about the effectiveness and harms of opioids. But even if they do have a lot of concerns about effectiveness and harms, it doesn't actually maybe translate into prescribers doing anything differently. And of course, understanding about the availability of alternatives, none of which are particularly helpful anyway. And again, to reiterate, the lack of availability of alternatives is not a reason to continue to prescribe, because doing nothing is a healthcare intervention in its own right. So, having talked ourselves out of producing another set of opioid guidelines, we are trying to persuade prescribers that they should prescribe sensibly and that they should not think of opioids as anything different to anything else. If a prescriber prescribes an antihypertensive and the patient goes away and comes back and still has high blood pressure, the prescriber will not keep doubling and doubling and doubling the dose of antihypertensive until the patient dies. The prescriber will do something different. But we don't do that with opioids. Prescribers continue to increase the dose or change to another drug that has no improved efficacy in the hope that they will get a result in the end. So we treat opioids in a different way to how we treat almost any other class of drugs. So we came back to basics. So what is a good prescription? It works. Doesn't harm the patient, doesn't harm anybody else, which is important if we start thinking about abuse and diversion. It has to be acceptable to the patient. The patient must be in agreement with the plan. And of course, it must be a legal prescription. And I'm sure this is the same in other countries, but in the UK, the General Medical Council has very clear good practice in prescribing, as do the other professional regulatory bodies that supervise non-medical prescribers. And the fundamentals that you might expect are that you do a good patient assessment and you don't do something you don't know how to do. You prescribe in accordance with the evidence and you justify that. You have to be sure that the drug is actually what the patient needs, taking account of their comorbidities, and that would be physical and emotional comorbidities, and keep clear records, assess the outcome, and prescribe within the law. And as we know, that doesn't happen with opioids. So this is our guideline. Assess the patient, discuss the benefits and harms, agree what you're going to give, find out whether it works, and if it doesn't work, stop. And none of that is different from the guidance for prescribing any other drug. But the patient does not just come across the prescriber. The patient moves around a system that brings influences to bear on what happens in that clinical interaction. So, not only does a patient come and see us in the outpatient clinic, they will go to a number of different primary care practitioners, they will meet their community pharmacist, they will oftentimes attend the emergency department, they may have intercurrent admission to hospital for another condition where their prescription is changed. So they see many healthcare professionals who in their turn are influenced in their activities by managers who often have very little clinical experience. Certainly in our own institution, all of our managers have come via the administrative secretarial route with very few understanding clinical issues. Formulary committees who we hope are becoming increasingly informed, and certainly our formulary committee is very well informed on the benefits and hazards and cost effectiveness of drugs that we use. Commissioners of healthcare services, strategy, national healthcare strategy initiatives, and of course, in turn, the Department of Health and bodies in the UK, such as Public Health England and NHS England, their activities are somewhat influenced by political imperatives of the government of the day. Patients are also influenced by their family, so I quite often will prescribe a drug, and patients' cousin will say, no, you shouldn't take that, it's no good, or she told you not to take more, but I find if I take 10 times as much, it's helpful. And the media, there's quite a lot of stuff in the media about painkillers, and this is one of the routes that we're trying to change things in the UK. And I think what we have learned is understanding that complex system and getting all those people involved in trying to make prescribing change has a much better effect than a multi-professional group of people interested in pain sitting down together and making a pronouncement. So I'm going to talk about an initiative that works, and it might sound a bit odd, but just listen to the basics of it, because I think it's relevant. So we've produced some guidance on pain management in secure settings, and the reason that this is relevant is that the big issue, or the big clinical problem for practitioners working in prisons was misuse of prescribed opioids, pregabalin and gabapentin. And so one of the main drivers of this was for us to help healthcare professionals understand the roles of medicines generally in the management of pain and the role of these potentially troublesome drugs in particular. So we convened a representative stakeholder group, and that includes commissioning, the National Commissioning Board now, National Health England, NHS England. We included Public Health England, who determined policy on public health. We included the Department of Health. We included the Prisons Inspectorate, researchers, pharmacists, and a wide range of healthcare professionals. And this made sure that this document was in alignment with other policy initiatives. There are a number of following wins for this document: that obviously we had a finite, reachable target audience, so we could actually get to every healthcare professional in every prison. The project was very sparsely resourced, but it was resourced in terms of publication and dissemination, although the guideline members and collaborators gave up their time for free. And I think why it's worked is it endorses current practice, because what we're hearing from general practitioners working in prisons is that they're giving out pregabalin and gabapentin and opioids, which cause a huge problem, but actually they don't solve the problem of pain. And so us actually helping them understand that these drugs have a small role in pain endorses their current observations in clinical practice and empowers them in saying no to oftentimes very aggressive and threatening patients. And there were some very simple learning points here that have been avidly absorbed and acted on. Suddenly everybody understands that pain is complex, and in particular, they understand the importance of emotions and psychiatric comorbidity. So in my own outpatients clinic, general outpatients clinic, 80% of patients who come to my service have a pre-morbid psychiatric diagnosis or emotional trauma. And for patients who are stuck on high-dose opioids, 100% have a pre-morbid psychiatric diagnosis or emotional trauma. And usually that's associated with adverse childhood events, obviously physical, sexual abuse, and developing personality vulnerabilities. So understanding the demographic of patients with persistent pain is important. We have taught in this initiative the importance of assessment of pain and the multifaceted nature of that assessment. I'm not going to go into this now, but we have managed to debunk the notion that the WHO analgesic ladder, which was derived for the management of cancer pain, has any utility whatsoever in the management of non-cancer pain. It doesn't. But despite that, the WHO analgesic ladder is the commonest used guideline to influence prescribing of opioids. We've emphasized non-medication interventions and the importance of engaging everyone in the patient's environment. And that is easy in a prison because you have access and control to everybody that the patient comes into contact with. So we've worked quite hard with prison governors, prison officers, drugs workers, and other people who come into contact with the patient to understand what pain is, understand complexity, understand the role of medicines, and understand the problems of misuse. And we've had a multifaceted implementation strategy, including healthcare, including education events, not only for healthcare professionals, but for commissioners of services. The Faculty of Pain Medicine of the Royal College of Anaesthetists has developed a training program, which is now mandatory training for every person, certainly for every healthcare professional working in every prison in England, and also is open to all others, so prison officers, gardeners, cleaners, whatever. Everybody can come, so everybody wants to know about pain. We've worked collaboratively with non-healthcare professional groups. We have got healthcare professionals talking to non-healthcare professionals and overcome boundaries of traditional distrust. This has been backed up by a formulary which is derived specially for use in prisons, an evidence-based formulary endorsed by the National Institute of Clinical Excellence. We have in-reach services, which we are trying to roll out. I go out to local prisons and actually conduct pain clinics in prisons, and the healthcare professionals, mental health professionals sit in those clinics, so they begin to understand how we manage pain. And we're doing a lot about patient and public education. So for the prisons, we're producing material for the prisoners about pain and about pain medications. And we've been involved in a number of national initiatives reaching out to the general public to let them know about the poor utility of medicines for pain. And similarly, addressing the emerging problem of gabapentin and pregabalin misuse, we thought about what the best thing to do was, and we decided it was not to produce a guideline on how to use gabapentin and pregabalin, but it was to give people enough information so that they could make a clinical decision. So, again, we engaged policymakers, and this publication was funded and promoted by National Health Service England, who decide what healthcare services will be delivered, and Public Health England, who determine the public health of the country. And this document alerts prescribers to potential misuse. It doesn't say don't prescribe, but it says these drugs are misused, which is something that people didn't know. We give them enough information so that they understand that these are not wonder drugs and they don't work for everyone. And we also explain that there are a number of options for managing neuropathic pain, but we do not say what to use or not what to use. We say there are options. We do not tell patients how to identify and manage misuse, but we tell prescribers that they must be competent to identify and manage misuse if they're going to prescribe these drugs. And we talk briefly about the indications, the prescribing stats and the harms data. And certainly in the UK, I don't know whether this is so elsewhere, pregabalin and gabapentin particularly are prescribed widely outside their licensed indication for neuropathic pain and pregabalin for generalized anxiety disorder. And they are nearly always prescribed as an add-on for pain which doesn't seem to respond to anything else. So oftentimes used for low back pain and other non-neuropathic pains. So I hope you'll see where we're coming to with what we're doing about opioid prescribing guidance. And we're not producing a guideline. What we are doing is collating together a massive bucket of information which gives prescribers the information they need to make a good prescribing decision. And at the heart of this is not exposing the patient to harm and making sure that what is prescribed benefits the patient, and endorsing the need to assess the patient to see if that is the case, and if the patient does not benefit, to stop the drugs. And the resource is divided into assessing the patient and the condition, so it's outlining the complexity of pain and the need for a very wide assessment of a patient and exploring the influences of context on that healthcare interaction. We talk about best prescribing practice, which, as we've discussed before, is giving the right drug to the right patient, not harming them, prescribing within the law, and make sure you follow up the intervention. And then we have got some stuff which is not really a guideline, but it reflects various clinical aspects of the use of opioids. So this resource is not a guideline, it's an evidence-based resource which pulls together the harms and benefits. And prescribers use that to make a good decision for the patient in front of them. And that is got to be influenced by the individual's clinical presentation, comorbidities, and circumstances. It's going to be an online resource hosted by the Faculty of Pain Medicine, but is funded by Public Health England and National Health Service England. And it contains extensive lists to other resources and other reading materials. It is not guidance. It's not a manual about how to prescribe opioids safely, and it's not a recycling of statements from other resources. So we think that we may be able to make an impact on what happens from this point. We hope that prescribing practices will change, but we all have the problem of a huge cohort of patients out there already on high-dose opioids that are not making an impact on pain. And I think that we do need to focus on the new area of de-prescribing, and certainly in the UK and Australia, this has particularly come from the care of the elderly population, where, of course, prescribing of unnecessary drugs has particular hazards in relation to morbidity. And this is just quite an interesting paper to read. It's quite a busy slide, but it actually describes the influences that cause prescribers to be reluctant to reduce medications or to embrace the notion of de-prescribing. And it's quite an interesting read. And of course, patients are, there are many different views about de-prescribing as there are patients, but patients are often very anxious about de-prescribing. And I think it's very important, certainly when I see a patient in the clinic, I will spend 25 minutes discussing their pain and the intrusive nature of it before taking their medication history, at which point we can reflect that what they've told me in the previous 25 minutes suggests that their medication is not working. And when I do it like that, patients understand that the medication is not working because they have just described intolerable pain. And I think actually I'm finding patients an easier audience to get the message about de-prescribing than I am fellow clinicians. And this paper makes the important point that the push for guideline adherence and intensification of therapy and trying to reach that unattainable goal tends to push de-prescribing into the background. But this makes the point that discontinuation or not starting a drug in the first place, if it is a shared decision and it's agreed with the patient, is in itself the highest quality healthcare you could offer, and this is a very important message. And for the sake of opening up the discussion, I'm going to leave you with a thought I had at about 6:30 yesterday evening. And I just wonder, having buried myself for weeks in papers on guidelines, looking at all the guidelines that are out there, reflecting why we haven't made a difference, reflecting why we have opioid sessions at every meeting, that maybe we're all making it too complicated. And maybe the perception that opioids prescribing, and maybe other analgesic prescribing, is very, very complex, sends the message that the normal rules of good practice don't apply. And it may be eroding a prescriber's confidence in just making a good clinical decision for that patient, following it up and acting appropriately. And I just wonder whether the search to try and find the magic guideline that makes a difference is taking us further and further away from good, sound, sensible clinical decision-making. And actually, our hypothesis at the UK at the moment, and we will obviously report back in years to come, is that by stripping it all back, giving prescribers the information they need to make a good decision, but leaving it up to judgment and sound clinical practice will have a greater impact. and we can discuss that. Thank you.